Okay, good morning again. So this 11-year-old female walks in, skeletally immature, 20-degree curve. That's the scenario that I'll see in the office on Monday. The parents are distraught at even learning of the diagnosis, and then we're acting as fortune tellers because it seems sort of sad that I can't tell them with a great amount of surety whether this curve is going to progress or not. And the problem is prognosis is a central issue in AIS care. The vast majority of these small curves aren't going to progress, but it results in unnecessary x-rays, unnecessary visits, and unnecessary worry. But the problem is some of these patients will progress and perhaps even need surgery. And can we find them before they're pre-symptomatic and maybe do an earlier intervention? Well, again, with the onset of big data, we've got three treatment options: observation, bracing, and surgery. And this talk, which was a little bit reversed, we're going to talk more about the observation, prognostication, and bracing. So these are the various factors that we know make some difference in whether a curve is going to get worse or not. I'll talk to you today about growth and some growth parameters that you can use to predict whether a curve is going to progress. The reason we have to talk about growth is central to the prediction of scoliosis progression. We know that curves get worse during peak height velocity, and we need a better method than just looking at the pelvis to figure out whether they're skeletally immature, whether they're going through peak height velocity, and whether this curve will get worse. Traditionally, the Risser sign was the gold standard. It's readily available on every spine film, but the problem is it's subject to a lot of error. Parallax doesn't correlate well with chronologic age, and you can make some errors, especially in boys, with trying to predict peak height velocity. This is the classic Lonstein and Carlson study. They looked at chronologic age and Cobb angle as an incidence of curve progression. And we know that chronologic age doesn't match skeletal age very well in a number of different studies. Jim Sanders is credited with changing the way we assess skeletal maturity in children. He demonstrated that chronologic age does not equal skeletal maturity and calculated something called the CAP, or the curve acceleration phase. And in two subsequent articles looking at maturity assessment and then using that new maturity assessment to predict curves, we're able to be better at that. When he looked at the Pearson coefficient for looking at current maturity indicators, he found that the digital hand score was the best and most accurate. Look how far down chronologic age and timing to peak height velocity would be if you measured their height. And then ultimately, look how bad Risser stage fares in that correlation. So this is the key stage to identify when you're x-raying a child's left hand. If all of the growth plates are open, the epiphysis of the digits is a little bit wider than the metaphysis, and they're actually peaking, capping over the middle phalanx, then this is the curve acceleration phase, or peak height velocity. And then you can go through the various stages of further ossification from distal to proximal and ulnar to radial, till finally the only thing that's open in stage 7 is the distal radius. Now spine growth is over, you can wean them from the brace and tell them that their outcome is predicted. Jim Sanders only did this work with 22 patients. We duplicated his study with 168 and found that our statistics were virtually identical to his. And you can use this table looking at Sanders' score and Cobb presentation to predict whether their curves are going to progress. Subsequently, he's shown us that the timing of peak height velocity is very tight. Regardless of whether you're a boy or a girl, 90% of your spinal growth is over, but it's that last 10% that can cause curve progression. He also told us how much the spine grows per year, which is a lot higher than what D'Amiglio used in longitudinal data. And the new thing on the block after the hand x-ray is Brian Smith's work with the humeral head. And if you combine both of these, hand and humerus, you can get very granular and very accurate in predicting peak height velocity and how much spinal growth is left. We can also use the sagittal plane. In looking at the sagittal plane, various curves have different sagittal parameters. For instance, a thoracic curve has the apex a little bit higher. You get that dorsal shear at the lower end of the curve. Lumbar curves have a kyphotic component at the top, and they go into lordosis a little bit lower. So just from the initial x-ray in the coronal plane, looking at the sagittal plane, even before they get a 10-degree curve, we can predict whether that curve is going to progress. So that sagittal malalignment may be that pre-symptomatic feature that we can use to predict if curves progress. But Stéphane Parent and the group in Montreal is really far ahead in looking at this in 3D. They tried to develop a predictive model using these 6 factors as to whether the curve would progress or not. The plane of maximal deformity, such as in the Da Vinci diagram, apical vertebral rotation, just looking at what that apical body is doing, disc and vertebral body wedging at that apex. And this pathoetiology was described by Ian Stokes, wedging of the discs and vertebrae, and that vicious cycle with asymmetric growth and asymmetric loading. And when you look at the convex structures which are under tension and the concave structures which are under compression, there's growth inhibition on the concavity, which is why, going back to tethering, how physiologically you can understand how that would unload the concave side of the spine. Well, anyway, looking at the two-dimensional parameters, they were about 50% accurate at curve prediction. Not bad, actually better than Lonstein and Carlson, which we were using previously. And then when you add the 3D parameters of the spine, you increase your accuracy to 70%. And this is really good work that's now being tested at multiple centers in a prospective fashion. So for instance, two patients both presenting with 26 and 29 degree curves. First patient is predicted not to progress. Ultimately, immaturity, they did not progress. Second patient is predicted to progress. Maybe you would want to do more aggressive bracing or other novel treatments to try and avoid the curve going to 50 degrees. Genetics is all over the place. This is a disorder with high prevalence and extreme variability. We know that by the kinship coefficient, this is in fact a genetic disorder, with scoliosis patients being much more like themselves than random controls. Score was promising at first. We actually showed that this test is not very accurate. The red line's pointing to our external validation score compared to the manufacturer's packaging data. And what you're going to read about is that most of these disorders are consistent with a multifactorial inheritance pattern, some environmental effects which we don't quite understand, and other issues. And they compare it to autism because it's all over the place in different studies. Heterogeneity and variable penetrance you'll see in multiple studies. The other problem is we don't have an animal model. We don't have a bipedal organism that develops scoliosis. They've looked at the bipedal rat. Now what's promising is the zebrafish and knocking out the PTX7 gene. And surprisingly, the zebrafish spine looks relatively similar to ours with different regional variation in the sagittal alignment. When you knock out this gene in a heterozygous fashion, they get a small curve. When you knock out both in a homozygous fashion, they get the exact deformity in the axial plane as seen by 3D rotational studies. So when looking at the 3D parameters and feeding this all into big data, where are we? The indications for AS management are the same. We observe small curves, we brace moderate curves, and we operate on big ones. There are scoliosis braces available. Many of them are on the market. The spine core does not work, but the other rigid orthoses have shown good efficacy. The previous outcomes were bracing. There weren't well-designed studies, and the SRS was begging for a prospective randomized trial that subsequently Stuart Weinstein undertook. Our center was participating in this, where they took skeletally immature children, they randomized them to observation or bracing with the standard SRS criteria, monitored with an embedded temperature sensor, with the primary outcome being progression to 50 degrees or skeletal maturity. The brace study was terminated early because it was shown to be effective wearing a brace, and it was unethical to proceed because bracing works. And 75% of the time in the intent to treat analysis, it was successful. And it's a dose-dependent response of bracing. For instance, if you wear the brace the majority of the day, you're going to do much better at avoiding surgery than if you just wear it at night. Who to brace? Patients that are skeletally immature with moderate curve magnitudes, and brace them until skeletal maturity. Lori Dolan took this data again, now with the Sanders score, and now has an app that can predict whether your curve is going to progress. So traditional braces like the Boston and Wilmington use 3-point molding to do tissue pressure and corrects the curve in the coronal plane. The newer thing is to use three-dimensional techniques with coronal correction, derotation, and balance of the sagittal plane so that you don't actually lose lordosis, but you maintain lumbar lordosis. You need a good orthotist, brace majority of the day, allow them to participate in sports, and give them some freedom out of the brace. Maybe use enabling technologies to measure the tension, and an app which will remind them to wear their brace and enforce their compliance, because we know that compliance counseling really improves brace wear and brace success. And when bracing should not be offered is in large curves or flat-out patient refusal. And when is the brace stopped? We stop it at Sanders 7 because most spinal growth is over at that point, or when it fails as a curve achieves 50 degrees. And finally, just a word about scoliosis-specific exercises. We think that in combination with bracing, there is some promising RCT evidence that this will help the patient in combination with bracing, but perhaps not by itself. So your patients will be asking about that. The next steps are some other technologies such as ultrasound-assisted brace fitting, finite element analysis to see where to put the molds on the braces, and much better compliance monitoring. Thanks very much.